morning, everyone. Thank you. We did have a lot of COVID questions submitted, and a lot of them were very specific, so I'm going to generalize where I can. Any really specific situational questions should be addressed through your own neurologist, and we only have 15 minutes for this Q&A, so we will answer as many questions as we can. All right. So first, if you guys could just speak kind of generally on timing, who should be considering a third or fourth booster, or third or fourth shot, and then timing with their infusions.
Sorry, we were just playing Rochambeau as to who got to answer that one. So there is a in your handout on page 4, as I understand it, is a chart that kind of summarizes doses, who, when, timing around infusions and things like this. That's part on the Rocky Mountain website as well. Generally speaking, the general guidelines are you should complete a course. Usually, if you're talking about the RNA vaccines, that's 2 shots. If you are on B-cell therapies or S1Ps, things that affect, enough the immune response, as Dr. Piquet brought up, then you want to do a 3rd shot. Then you start talking about boosters, so kind of additional doses. That's where you start talking about usually roughly about 4 to 6 months after your first dose. And now if you are over 50 and immunosuppressed, you can get a second booster. Over the age of 65, regardless of drug, you can get a second booster. And then timing, we're looking for kind of towards the end of the infusions for B-cell therapies. I mean, for most other drugs, you're kind of on them consistently. Timing doesn't apply too much. But for those infusions that are every 6 months, trying to wait for month 5, month 6, if you're going to extend out your every 6-month infusion, a month or 2 is fine. And then letting those B cells kind of come back, and that seems to help with response for those antibodies. Again, you still appear to have really good T cell responses, as Dr. Piquet showed us, which means we still have some good protection. So having those shots, even though we hear constantly about how the antibody responses aren't great, they're helping still kind of with that immune response to it. So they're still helpful.
Can you talk a little bit about the non-infusion drugs and how they might affect the vaccine effectiveness?
So the non-infusion drugs, I'm assuming the oral therapies, or was there anything specific to that question? Or just none? Okay. So I didn't know if there was a question about a specific mechanism or a specific drug. So that one slide that I showed that had a summary of compiled studies and data looking at mainly B cell responses, although there were a smattering of T cell studies done. The vast majority, so including your Tecfidera and drugs and that mechanism, oral drugs, all had a clear antibody response. It was really only the S1P drugs, which fingolimod, Gilenya, Ozanimod, Siponimod. Am I missing one now?
Did you get Ozanimod?
And all the mods. Those are the S1. Those ones had a blunted, attenuated, or decreased antibody productions outside of the infusions. And when I say infusions, I am saying anti-CD20s. We did not see that necessarily with natalizumab or Tysabri. Hopefully that answers the question.
But other data with Tisabri has shown that the antibody responses appear really pretty good, right? Because the immune system systemically with those patients is really pretty good.
And then a confirmation if you got your vaccines and or boosters before starting an MSDMT, or if you are not on an MSDMT, are there any considerations?
Yes. So if we can control before is better when you have a, quote unquote, normal immune system. However, we do see if you go on and to get a drug like infused anti-CD20, even if you start that, after you got your vaccine, there may still be over time some decrease in those antibody levels, emphasizing the need to continue with boosters as kind of the landscape evolves in terms of numbers, which we don't know at this point.
Can I ask one question? So I think one of the questions that comes up a lot is, should I be checking for antibody levels? What do you think, Dr. Piquet?
So from the data that I just showed you, antibodies are not the full picture. They're an interesting piece, but if I check your antibody levels and they're low as to be expected, for instance, if you're on rituximab, I think looking at that number and seeing they don't exist probably causes more anxiety than good. We would love to have a commercial T cell assay. That would be the next step.
Yeah, I think the one place maybe to check them is if you're thinking about Evusheld, if you have good antibody responses, maybe there you need to get then Evusheld, so it might help decide whether to do that or not. Remembering one of the hard parts about this testing is it doesn't tell you if you're protected or not, and it doesn't mean that you're protected against that next variant to come along. And so I think that that's a little bit of the challenge why we're dragging our feet on saying like everybody should get checked and everybody should be getting Evusheld, those kinds of things. I don't think there's a problem with doing some of those things, but just kind of knowing how you're going to use the data for that.
And since you mentioned Evusheld, let's throw that into the mix. Do you have thoughts on timing of it with infusions and kind of how much does it add to a person's protection in addition to boosters and vaccines? Particularly, we had several questions about folks wanting to interact with people who are unvaccinated. Does Evusheld give them a greater measure of protection?
I think it definitely helps provide some level of protection. I think the important point, as Dr. Piquet brought up, was you need those T cells as well, right? So this is only going to give you a little bit of protection. And it's understanding that you're not getting that full protection just with these monoclonal antibodies. They work really well for patients who can mount that T cell response, because then you're kind of filling in the gap of the immune system that you can't fill in. As far as timing, it's an antibody, so you have a lot of different antibodies in your system. So it doesn't really have any concerns for interactions with any other drugs, with any infusions, other disease-modifying therapies. It's more of trying to separate out with the vaccine by a couple of weeks, primarily. Otherwise, you can kind of do it however, whenever.
Yeah, and just to reemphasize that Evusheld is not a vaccine replacement. It is a addition to the vaccine. So just providing you with that extra level of protection if you don't mount that full response.
And we also had several questions pertaining to both travel, international travel, and then also, again, just interacting with folks who are unvaccinated. So I know, Dr. Alvarez, you ended with a great way to kind of think about risk in the future. If you want to just summarize that again?
Yeah, don't swap spit, and then look at sort of the risks out there. And then if you're one of my patients, the only requirement for international travel is you bring back pictures.
Kind of looking forward, how are you guys predicting how long the vaccines will last, how often people will have to get them? Is COVID turning into just another flu?
Are you aware of them working on any vaccines for the new variants, like any updated vaccines? I
My-
am not, so I'm just kind of curious. And this goes for Dr. Corboy or Dr. Gross, if you guys are aware of that as well.
My understanding was that they were trying to modify the mRNA vaccines, perhaps to include Omicron, but I don't have any hard, fast, and insider information on that. It's clear even in normal individuals with a normal immune system that are below the age of 50 that you still see this waning antibody, circulating antibodies in the blood after the vaccine, usually around 6-ish months. It is not probably obtainable to just keep getting a new vaccine every 6 months. Perhaps kind of focusing on those high risk populations makes the most sense. But I do kind of see this as this virus is here to stay. It's not going to disappear. It's not going to go away. It's going to continue to evolve just like life evolves. And I suspect, just like we kind of line up for the flu shot every year, this is probably kind of heading that direction, but I don't have a crystal ball. And whatever I say today in the land of COVID could be wrong tomorrow.
But I think that's a realistic expectation. I mean, as long as this becomes endemic and kind of circulates and doesn't go away, which the other, coronaviruses haven't. So I think, changing this vaccine is about as easy as it gets because they're making RNA and it's just a matter of changing it a little bit. So realistically, this shouldn't be a hard vaccine to kind of keep changing every year, kind of like they're changing the flu vaccine. And then potentially, they'll come up with new and improved vaccines and everything else like that, but, probably combined with the flu shot at some point.
I read that T cells are the main fighters of COVID. Doesn't Tysabri lower T cells? Will I be able to fight off COVID if I'm getting Tysabri monthly?
Do you want Tysabri? I could do Tysabri, but so Tysabri actually doesn't lower your peripheral T cells. So in the blood, in the bone marrow, and your lymph nodes, it does not allow those T cells to get into the brain, in which COVID replicates in other places outside the brain. So it actually doesn't really impact that much at all.
If a patient gets COVID, do you recommend the monoclonal infusions? And then is there any greater risk that we see for long COVID for MS patients?
Yeah, so I think the biggest thing about getting tested when you have symptoms is trying to figure out if it is COVID or something else, because we're starting to see everything else kind of come back up now. And I think that one of the biggest things now that we have options is, to take advantage of them. Like, this idea of like, I got really mild symptoms. Should I, do something about it, or should I just kind of hang out at home and kind of do that? Remember, the magic number is 5 days. And within those 5 days, you have a little bit of flexibility, but there's always some delays to get into an appointment to get those treatments and things like this. So don't wait until day 5 to start doing that. And I think I would push for anybody who has anything to kind of push out for these treatments. These treatments appear really safe, whether it's monoclonals or the Paxlovid. I've seen a little bit of hesitation with the Paxlovid from our clinics here. I think it's you get what you kind of can, and if you care one way or the other, I've seen huge bounce back stories with both options, with either the monoclonal or the antivirals, where like it goes in and people just feel that much great. And sometimes it's one of those where people can feel kind of good, 5-6 days, and then day 7 is kind of when things start to kind of hit the fan a little bit. And at that point, then whether you still have the options, not being able to get the monoclonals because all of a sudden now your oxygen levels have started to dip and they're saying, hey, you can't get the monoclonals now. So trying to take advantage of those windows to get these, I think, becomes really important. And we have the supply.
Dr. Piquet, the study that you talked about, the results seem to line up with others. With the N being 34, can you put some context around that as to how big of a study it was?
Yeah, so with 34 patients, it's about, there are bigger studies out there, but it's kind of in line with what we're seeing. The important thing that even though we had 34 patients, we were able to statistically power that. So, I mean, that even though it's a low number, it was enough to show statistical difference, basically. So 34 was enough. There are bigger studies out there. One of the other studies, which I did not mention in my talk that we are involved with, is with NYU, sponsored by Genentech Roche, specifically with ocrelizumab following patients over time. And that one's about 60 patients. And so when you add kind of everything together and the data is aligning, that's always a nice thing.
Thank you. We're going to have one more question and on kind of a bigger picture, future research topic. Since COVID causes brain shrinkage, cognitive decline, et cetera, does this lend support to the theory that MS is caused by a virus? Is anyone looking into that?
I love small questions. All right, perfect. So I think some of the brain shrinkage part makes a little bit of sense. Anytime you look at aging as something that leads to brain shrinkage, and yes, all of you guys are losing brain, whether you have MS or not. Things when oxygen levels start to drop, as COVID does, and things like this, the brain doesn't like that, and part of that is losing brain volume. I think there's a little bit less evidence for how much COVID actually gets into brain and directly affects some cells. We can see that the immune system sometimes can get a little bit ramped up and things like that. So I wouldn't be too surprised to see that periodically, but this isn't a virus that affects directly the brain. There might be a lot of secondary effects on the brain. As far as long COVID goes, it's a challenging because if you affect the lungs don't repair themselves really fast. They repair themselves better than the brain does, but it can take a really long time to be able to repair the lungs to kind of function properly. And to see patients who have a bronchitis, reduce oxygen carrying capacity, all that kind of stuff for months after COVID is very common. I think long COVID gets restricted sometimes to kind of issues around fatigue and things like this outside of that as well. And so it's a little bit hard to kind of separate out what we mean by some of these different names. I think the second reference to that was a little bit around the Epstein-Barr story, that I think there's going to be a little bit more on that this afternoon. So I'll pass the buck on that one.
Wonderful. Thank you both, doctors. If you would like to see all of the information that we've compiled about COVID-19, we do have a page on our website, mscenter.org. It's got all of Dr. Alvarez's previous updates. It's got that chart that talks about vaccine boosters, shots, timing, and it's got several great FAQs on there as well. So I encourage you to check all of that out. And you can continue to submit questions for the general Q&A that will close out the conference in just a few presentations.
I'll put in a plug as well. Haley is sitting in the back tables and is happy to talk to anybody about research studies that might be going on. There is a booth way at the far back that's looking for healthy people. I'm not sure how healthy we all need to be for that study, but between ages of 40 and 65 is who they're trying to recruit. So, you know, if your significant others, kids, brothers, sisters are excited to be part of the Healthy Control Project to understand a little bit what some of the potential biomarkers look like in the future, you know, ask them where they might be at other sites and things like that. So thanks a lot.